Welcome to the Wednesday webinar. Looks like we still have a few people joining, so we'll just give it another minute or so, and then we'll start. Good afternoon, everyone, and welcome to this week's National Bleeding Disorders Foundation Wednesday webinar. My name is Fiona Robinson, and I am the series host. Today, we are celebrating Factor 10 Deficiency Day. A few days ahead, it is actually on October 10th, and we're celebrating with an exploration of the Odyssey of Factor 10, voices, symptoms, and the evolution of care. This webinar is being recorded. The recording will be available shortly after it ends on the NBDF website, bleeding.org. We encourage you to ask any questions you may have today. You can ask your questions by using the Q&A feature at the bottom of your Zoom screen, or by putting your comments into the comments section of whatever platform you're using to watch today. So if you're joining us by LinkedIn, Facebook, YouTube, you should be able to put your questions into the comments there. And then following our speakers' presentations, we'll put your questions to them. Today, we have the rare pleasure of being joined by two experts in this ultra-rare bleeding disorder. Ariel Lorraine, a lived experience expert with Factor 10 deficiency, pursuing a PhD in pharmacology and neuroscience at Southern Illinois University, Edwardsville, and Dr. Brian Branchford, a pediatric hematology physician scientist at the Varsity Blood Research Institute in Milwaukee, Wisconsin. I'd like to thank Ariel and Dr. Branchford for joining us today. I'd also like to thank Kedrion Biopharma, our Factor 10 awareness and webinar sponsor, for making this webinar possible. Just before we hear from our Factor 10 experts, I'd like to ask Joe Gorman, Vice President, U.S. Specialty Sales Rare Disease Biotech at Kedrion Biopharma, to say a few words as part of our celebration of Factor 10 Day.
Thank you, Fiona, for the warm welcome. Much appreciated. It looks like we have 34 amazing participants on the line today, which is super encouraging for such a warm and awesome turnout to learn about Factor 10 deficiency. On behalf of Kedrion Biopharma, it's a pleasure to welcome you here today. MBDF's Wednesday webinar, The Odyssey of Factor 10 Voices, Symptoms, and the Evolution of Care. Should be amazing content today. We're honored to partner once again with MBDF to support Hereditary Factor 10 Deficient Awareness Day, which is so great to be able to have a day dedicated to education, knowledge, and awareness around this ultra-rare disease state, and that really just helps shine a light on this truly ultra-rare bleeding disorder. Our relationship with MBDF continues to grow year over year. This webinar is a great reflection of that evolution. And last year, we had this session as well. It focused on the patient voice, which was super powerful and moving. Through conversations over the summer, we were able to expand the format to bring a broader educational perspective. So with that, today, you'll hear not only from a patient living with Factor 10 deficiency, but also from, of course, a respective healthcare provider, allowing us to bring together real-world experiences and clinical insight. This type of collaboration is exactly what drives better awareness, earlier diagnosis, and ultimately what we're looking for, better outcomes for patients and families with Factor 10 deficiency. So some speaker highlights here from you all. Again, we're thrilled to have Ariel join us. Ariel's been a part of the Factor 10 deficient community for many, many years and has been a great just a spokesperson and connector of people in this area. So Ariel, we really, really appreciate you. It's inspiring to see how her journey has evolved, and we're grateful that she's sharing her story today. And congratulations on your one-year wedding anniversary and all the fun research you're doing. It's fun to kind of virtually follow you and see your amazing career progress. We're also pleased to have Dr. Brian Branchford, whose relationship with the Factor 10 deficient community continues to deepen through his research and amazing work. These engagements are helping shape important conversations, including his role in Factor 10 future breakout sessions as well. So at Kedrion, we're proud to sponsor these initiatives we're proud to sponsor initiatives like this because ultimately, awareness truly matters for not only for the healthcare community, but for the patient community as well. Factor 10 deficiency is ultra rare, and but together through education, community, and shared voices, we can make a difference in helping patients get to the right diagnosis faster. there's so many patients out there that are suffering from factor 10 deficiency who just don't know it yet or have signs and symptoms but haven't tackled the diagnosis or treatment option yet. And that's the goal here today. So thank you to Nicole and the entire National Bleeding Disorder Foundation team for their partnership. And thank you for joining this important session. We're looking forward to some really meaningful and important dialogue and discussion. So with that being said, I will turn it over to you, Dr. Brian Branchford.
Thanks, Joe. Thanks, everybody at Kedrion and at NBDF for helping set this up. And thanks, everyone, for joining us. So I'll be going through some of the background of factor 10 deficiency before we hear a bit more about what it's like to really live with this disorder. So let's move into the first slide. Ultra rare disorder, Joe said, which is, you can see the diagnosis exists in about 1 in a million patients. There are some closely located areas that it might be as common as 1 in 200,000, but it's a autosomal recessive disorder. And what that means is autosomal means it's not linked to the sex chromosomes, so it can affect male and females equally. But that means that a father and mother who carry gene for the disorder, as you can see in this graphic, the blue gene here represents the disordered factor 10 protein, and the red is the normal or wild type factor 10 gene. And when two heterozygotes or half affected parents get together, they have a 25% chance of one child getting both affected or abnormal genes, 50% chance that they would produce offspring that have carrier status just like them, and then a 25% chance of a child with both wild type factor 10 genes, so normal factor 10 levels. So we talk about the diagnosis 1 in 200,000 to 1 in a million, but there might be as high as 1 in 500 carriers out there. Next slide, please. So we talked a little bit about how you get it. What happens if you don't have enough factor 10? So factor 10 is a critical component of the clotting cascade. It's literally the central point when we diagram this out. So the idea behind the clotting cascade is that there are a bunch of proteins that work together in the body. These are all identified by Roman numerals, usually relating to the order in which they were discovered. And they come together and activate each other in sort of this cascading format, eventually producing fibrin, which are the long, skinny strips like the fibrin or fibers that might be in your shirt. And that comes together and kind of cross hatches, and that leads to your clot that can help prevent bleeding. But you see here how the intrinsic pathway on the left in sort of the teal green and the extrinsic pathway in the lighter blue come together to form a common pathway in red, and that common pathway kicks off with factor 10. So if factor 10 is missing or deficient, there's no way to progress through this pathway to develop fibrin and make these clots. Let's go to the next slide. So what might that look like? Symptoms, I have started here with all the patients that might suffer bleeding with factor 10 deficiency, but then we'll get into a couple special patient populations worth special consideration. But in general, this is excessive or prolonged bleeding. Once you start bleeding, it's hard to stop. It doesn't necessarily make it easier to start bleeding. That has to do with usually blood vessel damage from an injury or a surgery, or even real minor things, just movement through daily life can cause tiny microscopic tears in our blood vessels, or a sneeze, something like that. And usually that's not a problem, but with a factor 10 deficiency, that might lead to bleeding that then doesn't stop. And there are mild, moderate, severe cases. We worry about spontaneous bleeding, severe bleeding, and life-threatening bleeds. So we pulled information from a study that looked at 102 subjects with hereditary factor 10 deficiency, and of those 42%, well, 42, which is almost 42% presented with bleeding symptoms. So of those 42, 55% had easy bruising, hematomas, which is like a large lumpy bruise, epistaxis, which is recurrent or prolonged nosebleeds, hemarthrosis, blood in the joint that A, hurts, B, reduces the range of motion of the joint, and C, can really irritate the joint and lead to thickening of the synovium, or the special tissue that lines the inside of the joint. And over time that thickens up and just sort of builds up, and you get like a wad of tissue where there should be a joint for free range of motion, and that ends up restricting movement. Continuing to decrease in prevalence, we see gum bleeding in 31%, intracranial hemorrhage, so that's bleeding within the skull or within the brain, gastrointestinal hemorrhage, which is bleeding in the throat or the stomach or the intestines, and then finally hematuria, which is blood in the urine. So importantly, we see that some of these patients, up to 55%, have bruising, but of patients who have bleeding symptoms, 1 in 5 may have had an intracranial hemorrhage. And sometimes it happens and you really notice it because there's severe loss of function and stroke-like symptoms or terrible headaches or things like that. Or sometimes patients accumulate small intracranial bleeds that slowly over time lead to decreased brain function. Let's move on to the next study, please. Looking specifically at females. So the majority of women with hereditary factor 10 deficiency have a history of heavy menstrual bleeding, which there are specific research-based scoring systems to do that. Usually in practice, I say to my patients, if you're changing your protection, pads or tampons, menstrual cups, period underwear, that sort of thing, if you need to change more often than about every 2 hours, that's considered heavy menstrual bleeding. So that puts people at risk for severe anemia, which may lead to minor symptoms like headache and fatigue and dizziness, or it could lead to more severe anemia where there's trouble getting oxygen to the important organs. And in between there somewhere is iron deficiency, which can lead to more of those problems also. But a study looking at 17 women of reproductive age found that probably 70% of them have heavy menstrual bleeding. And in addition to just the monthly menstrual cycle, there's also pregnancy-related complications like increased risk for miscarriage, uterine bleeding, postpartum hemorrhage, which is severe or heavy or prolonged bleeding after delivery, and sometimes even preterm labor. Looking at post hoc analysis, which is a separate study of a subgroup of patients in a larger study, they saw that 5 out of 10 of them had such major menstrual bleeding they needed a blood transfusion. So now these women have to consider all the risks of a blood transfusion from an unrelated donor, reactions and viral infection transmission and all these things. The risks are very, very low, but it's still a new exposure that is necessary as a result of the menstrual bleeding, as a result of the factor 10 deficiency. So let's move on, please, to neonates. So neonates are babies in the first month of life. This is when we see a lot of the more severe bleeds because usually this is before the disorder has been diagnosed. So we talked about intracranial hemorrhage, GI bleeding already, umbilical stump falling off, post-circumcision, there can be bleeding. Even the heel stick, the little poke that we do to get blood to send off for the newborn screening tests. Abnormal bruising, just sometimes bruising around the rib cage from being picked up or handled, or the legs moving when we're changing diapers. So we mentioned this study previously with 102 adult and pediatric patients, 42 of whom were symptomatic. That was what I went through a few slides ago. But these life-threatening or organ-threatening bleeds presented at a median age of 9 or 10 days. So that means the average patient was having a bleed in a tiny little brain, and that's very difficult to diagnose and to manage and to treat. Performing neurosurgery or a gastrointestinal surgery procedure to try to help that is very complicated in someone who's just about a week and a half old. So I think it really points out the importance of understanding genetics and who's at risk, and identifying early the concerns for this, and maybe getting some treatment started before we get to the point of these severe bleeds. And you can see we don't have a whole lot of time before we end up with permanent impairment or mortality or death in these neonates as a result of bleeding in the brain that can't be stopped. Okay, next slide, please. So how do we do that diagnosis? So I have here a triangle that sort of shows the broader questions narrowing down to more pinpoint questions as we start to target something like this. But if there's a history in the patient, or I would say the family, of excessive or unusual bleeding, have we ruled out some of the other more common things, platelet disorders, hemophilia A or B, or hemophilia C, factor 11 deficiency, et cetera? Have they been screened for rare bleeding disorders? That's how we consider focusing in on something rare like factor 10 deficiency. So the key is to start broad and not just say, well, hemophilia is pretty common, let's check for that. And then you might miss something like factor 10 deficiency if you're only looking at a factor 8 level or a factor 9 level. So it's important to cast the net wide to begin with. So we start with pretty standard lab tests. You can see on the top left here, the PT or prothrombin time, which is prolonged, or the activated partial thromboplastin time. These are essentially clotting times, looking to see which factors are involved and where you might focus specific studies after there. If both of those are prolonged, then we suspect something in that common pathway of the clotting cascade, that red section of factors that I showed you several slides ago. And in there, the first one is factor 10. So that we would take a look at that. And if that looks like that's a low level of the protein itself, the antigen, or more importantly, the activity, because what you don't want to do is say, well, the level of factor 10 protein is fine, so that's not the problem, because some people's hereditary factor 10 deficiency is not a problem with decreased amount of protein. They have enough, it just doesn't work well because of their particular gene variant. So that's why we check the activity specifically. And then we can get into trying to understand which gene variant affects a particular individual, and then based on what we know, which is limited because of the rarity of the disorder, but this may be able to help us predict to some degree how severe the bleeding is or how certain treatments might be managed. Okay, next, please. So classifying this, initially we had done what we've done with other severe bleeding disorders like hemophilia. Hemophilia A affects 1 in 5,000 males in the US, and so it's relatively common. We thought we could use the same sort of thing for factor 10 and called people with activity less than 1% severe, 1 to 5% was mild, 5 to 20%, moderate, and then 5 to 20% was mild. Higher than 20% usually is not an issue, not related to bleeding, doesn't need to be treated or medicated before surgeries, that sort of thing. But more research, more patients gathered, more correlation between activity level of the factor 10 and the bleeding symptoms. We found that levels even up to 10% are probably correlated with a severe bleeding phenotype. And the phenotype is just how the patient is expressing or demonstrating their bleeding. 10 to 40 moderate, and then 40 to 65% mild. So we've really kind of broadened the category more recently to include more people and get that diagnosis performed earlier, which can allow us to intervene earlier and hopefully make more of a difference and preserve joint function or avoid life-threatening intracranial hemorrhage or GI bleeds. Next, please. And then just one last slide about treatment, and then we'll get to a little bit more in depth about patients and how their experience has been as told to us in a survey. And then you'll be able to hear from Ariel about her experience as told to you directly, which is even better. But considerations for treatment of hereditary factor 10 deficiency. First, we consider, are we going to treat on demand, which is like give factor 10 containing products or ancillary products in response to a bleed? Or do we do a prophylaxis regimen where we give regular amounts of factor 10 products to try to prevent bleeding? Or intermittent prophylaxis? There are some patients that say, most of the time I do well without bleeding, but I need to get some extra factor 10 around the times of my period every month. Or I have mountain biking every Saturday, so I need something before that, but during the week I don't bleed. You can see on the bottom left some of the progressive considerations there in conjunction with the options I've listed on the top right. You know, blood transfusions don't replace any factor 10, but they provide supportive care. If you've lost a lot of blood because of bleeding related to factor 10, you can have blood transfusions to replace that. The fresh frozen plasma, or FFP, on the left side of the bottom left figure does have factor 10 as a plasma protein in it, but it takes a lot of volume, so the patients have to have good kidney function and good heart function. There's risk for volume overload, allergic reactions, pathogen transmission, because this is human-derived plasma. Prothrombin complex concentrates have an unknown concentration of factor 10 and a thrombosis risk, because if you have to give repeated doses to get the factor 10 level up, you're also building up levels of factor 2 and factor 9 and factor 7 usually. Then there's factor 10 concentrator, plasma-derived factor 10, which is that final arrow on the bottom figure and in the middle of the other one. That's a single factor product of isolated factor 10 concentrate. And then I have some of these ancillary methods listed under options. The tranexamic acid is an antifibrinolytic, so it slows fibrinolysis or clot breakdown. So once you can make a clot, it helps prevent the breakdown of it. And it's really good for high clot breakdown areas like mucous membranes, the mouth, the nose, the reproductive tract, the GI tract, that sort of thing. Hormone modulation. So this is the phrase I use instead of birth control for hormones that people might take or an IUD that they may use to manage periods, whether or not it's also used for birth control. And then conservative management, so that's like rest and ice and compression, that sort of thing. The general points on the bottom is that treatments may change. You'll see a little bit of that later. Bleeding symptoms can be different for people with the same factor 10 activity levels. And because of heterogeneity of bleeding disorders, the complex pathophysiology of the bleeding, and an underappreciation of the impact, development of therapies specific for this disorder outside of the plasma-derived factor 10 concentrate has lagged. So let's move on to this survey. The setup here, this is about a survey I worked with Kedri on a few years ago now, called HFXD in America, that we did to try to better define the patient journey and their caregivers. And the idea is just that we want to try to increase awareness and have people be able to share their story with providers and see how this disorder affects their life in ways that you can't just get by counting emergency room visits or factor orders or that sort of thing. Next slide, please. So we got about 30 patients and about 50 caregivers, and we asked about their diagnosis process, and people's interpretation of that was mixed. Said about half patients and caregivers found it easy or somewhat easy, but about a quarter of them said it was difficult. And that may be part of whether they had genetic risk factors or not, but let's move on to the next one. What event led to the diagnosis? So just under half of patients were diagnosed at birth. Overall, the average age was about 4 years old. But 31% of them experienced a bleed that required hospitalization that led to the diagnosis. So they were not identified before some kind of catastrophic bleeding event. Next, please. A little over a third of patients had treatment that was initiated more than a month after diagnosis. So there still is, I think, work to be done making that more efficient. We know what's wrong. Let's start treating it. But almost 75% started their treatment within 3 months. Okay, next. So the current treatments, I had another slide here called treatments people had ever received, and most of them had received most of these things. But after trying out a bunch of different things, you see mostly what people settle on, which is what they were currently using. So about 40% of them were using fresh frozen plasma or prothrombin complex concentrate or blood transfusions, which don't even treat the factor 10, just supportive care. So only about half of them are getting single factor treatment. And you see the other ancillary options there. So some people are receiving multiple treatments. Okay, next, please. Did the treatment help? Mostly is the short answer. About 2/3 of patients on the left side were satisfied with how their treatment controls the bleeding. More than 70% of them agreed their treatment improves their quality of life. On the other hand, the caregivers, less than 60% of the time were satisfied with how treatment controls their patients' bleeding, but 80% of them felt the treatments reduced their own caregiver burden, which was interesting. Okay, next. Bleeding episodes, I wanted to keep this in. About 2/3 of patients have between 1 and 3 bleeding episodes every 4 weeks. A quarter of patients have none, but there's a few, a bleeding episode every 4 weeks is 12 bleeds a year. 3 bleeding episodes every 4 weeks is 36 bleeds a year. That would be far beyond what's acceptable for other bleeding disorders. And I think it's time that we providers move things towards that direction for people with factor 10 deficiency also. Next, please. The highlights here, we look specifically at the female population. Of those 38 patients we had, I think 9 of them completed the Menorrhagia Impact Questionnaire, essentially saying that they reported heavy or very heavy blood loss during their most recent period, which matches with data I showed you earlier. 2/3 reported that bleeding limited their physical activities moderately or more, and more than half the patients reported bleeding limited their work and social activities at least moderately. Next. The last slide or two I have just look at quality of life and well-being. And as you may be guessing from the reports of bleeding, maybe not adequately covered by treatments or the menorrhagia affecting work or social life, we performed a short form health survey assessing overall quality of life with high scores indicating greater functioning. So the average in the US is about 50. So out of 24 people that responded to their physical component about the movement, they scored 45. So lower quality of life compared to the general population there. And the mental component, just about 48 or 49. So just a tiny bit lower than the overall population. And the Hemophilia Well-Being Index on the right assesses patients' well-being a little bit more directly. We modified this for use with factor X deficiency after talking with the developer. Here, a lower score between 1 and 32 indicates better well-being. So a score in the high 20s or 30s is considered good. And here, the 27 patients that responded to this part had an average score of 20. So that's a relatively low well-being score overall. Next. This, I believe, is my last one. So we asked the caregivers about the impact on them too. So these are the friends and family members of, they're the care providers. So we used the Hemophilia Caregiver Index, again, that we adapted for use with factor X deficiency. Out of 35 points, the burden score was 16, which is relatively high. And it was the impact of the symptoms the most. So they worried about the patients they were with bleeding. But kind of to end this on a little bit better note, to put a good spin on it before we move into Ariel's talk, is the positive emotions in the Hemophilia Caregiver Impact tool. Patients out of 5, or the caregivers scored 4.2, which is high on this scale. So positive aspects of caregiving, including high self-worth and inner strength. So they were able to take something from that too. So that's a little overview of the experience of this from my end and from some patients that we surveyed. But now I'll turn it over to Ariel to tell you what her journey's been like.
All right.
Thanks.
Thank you, Dr. Branchford. And thank you for the opportunity to allow me to speak and kind of share my story. So my name's Ariel Lorraine. I have recently gotten married. We just celebrated our first wedding anniversary last week. So that's been very exciting. I am very fortunate to have such a supportive husband. A little bit about me is I love nature, exploring, taking hikes outside, and spending time with family. I also have severe factor X deficiency, less than 1%. I didn't start with that as my introduction because it is not the most important thing about me, though it is the topic of what we're talking about today. I prefer to kind of view my life as my opportunities and not let my bleeding disorder define who I am or what I do. So like I mentioned, my family is very important to me. We are a very tight-knit community because of, the things that we've experienced with having a bleeding disorder. My older brother also has severe factor X deficiency, less than 1%. He was born 2 years before I was and had a brain bleed as an infant. So I have been kind of the beneficiary of my parents learning how to deal with the bleeding disorder and the doctors around learning more about factor 10 deficiency and how to treat it. So after my brother's bleeding issues, he was started on prophylactic treatment. And then when I was born, I was diagnosed at birth and started prophylactic treatment then. So I've been very fortunate to not have experienced a severe bleed requiring hospitalization or having a permanent, more lasting impact on my life. So next slide, please. A little bit about my story. Growing up, factor 10 deficiency obviously is a very, very rare bleeding disorder. My family did not have a history of bleeding disorders. Nobody else that my parents knew had a bleeding disorder. They hadn't even heard of hemophilia. So learning about factor 10 deficiency was very much a shock for them, especially when my brother was born. And at the time, the internet was very young, so it was not easy to just Google what is factor 10 deficiency. My parents had to go to the the medical school and look at physical papers about factor 10 deficiency to try to find any information about it or how to treat it. So that was very difficult for them. We didn't know anybody else who had factor 10 deficiency. The first person that we met was actually at a bleeding disorder conference when I was 16. So that was a pretty big deal for us. And later we've been able to attend more conferences and meet others who also have factor 10 deficiency and just kind of compare stories and see similarities and differences between, other people's experiences with factor 10 deficiency. So as I was growing up, I was on prophylactic treatment, but it was a complex of several different factors. It was always kind of a balance, like Dr. Branford mentioned, of getting enough factor 10 while preventing unnecessary clotting with too much of the other factors. So I still had bleeding issues. I still had to be very careful, even though I did have treatment. I had a lot of kind of the classic bleeding disorder symptoms. I had nosebleeds a lot as I was growing up, especially before I was like 10 or 12 years old. Um, they usually would last like a half an hour to an hour. The longest nosebleed that I had was about 3 hours long. So that was a long time just standing over the sink holding tissues up to my nose. Um, and then later, as I grew up, um, menstrual bleeding became a lot more of a problem for me. I also had some joint bleeds. I used to be in a dance class and ballet classes, but I was not able to continue with that because I just had a lot of ankle issues doing that. So sports were also not really an option for either my brother or I growing up. So I turned to more of music outlets to kind of have, the camaraderie that one would feel with a sports team. However, in high school, we had a marching band, which some people really like. I was not one of those people, but I had a hard time continuing with marching band because our practices were very rigorous. We were out there nearly as much as the football team, and I just could not keep up. My knees and ankles could not take it. I would have to come home and just lay on the floor and put my legs up on the couch and just cover my legs with ice because I was having a lot of joint issues. So I missed a lot of the practices. I ended up not being able to continue with band because of that. Um, and then later, I had quite a bit more issues with menstruation and heavy bleeding, which really put my body kind of out of whack in other ways. So because I was having so much bleeding with menses, I had problems with my knees and my ankles and really just being able to continue moving forward, which was difficult because my brother also had a bleeding disorder, but he wasn't having a lot of the bleeding issues that I did. Although we have the same level severe factor 10 deficiency and we were taking the same therapy, my doctor frequently told me, well, you should be fine because your brother isn't experiencing these kind of joint issues. And your trough level, so like the lowest activity for factor 10 I was getting, even with therapy, was about 12% at the time. And like Dr. Branchford mentioned, according to the hemophilia bleeding scale, that should not have much bleeding associated with it. But I was experiencing a lot of problems, and that's really all my doctor could say about it was, well, you shouldn't be experiencing that because according to the scale that we do have, that's not typical. So I was referred to several other specialists, like for arthritis because of all of my joint pain, and then later to a dentist because my bleeding got so bad whenever I would brush my teeth, my gums would bleed. And everybody kind of just said, no, that's not the issue. You don't have arthritis. You don't have anything going on with your gums. So I ended up having to find another hematologist that would kind of listen more to my bleeding experiences and take that into account. So later in high school, I also learned how to self-infuse, which was a huge deal for me because I grew up with a lot of, the hemophilia boys going to infusion camps and people learning how to self-infuse when they were like 9 or 10. And I did not learn until I was 16 or 17. So I felt a little bit behind because of that, but I eventually learned how to self-infuse, and this picture shown here is me using a vein in my foot because I could not let all of the boys outdo me, and they were only okay with using their hands or the insides of their elbows. So I decided I'm gonna try my foot. It was successful, but yeah, so learning how to self-infuse and being able to take care of my body quite a bit more allowed me more independence with my care. So then I was able to move away to college, which is the next photo on the right side of the screen. My mom took this photo. I just find it very funny that I'm holding a stuffed animal and just walking away moving to college. But yeah, so college, I graduated with a chemistry and biology degree, and I met my now husband. So science was always a big part of my life because of my bleeding disorder, and that stemmed through my degree. Next slide, please. So now, fast forward a little bit. As was mentioned at the beginning, I am studying to get my PhD in pharmacology and neuroscience. So I'm studying drug development. A lot of this was inspired by my experiences with having a bleeding disorder and being able to receive treatment. So I wanted to go into the sciences and use kind of what I've been given to try to help other people who are in need of a treatment or a medication. I have also been able to learn how to take care of my bleeding disorder quite a bit better and kind of manage a lot more of my bleeding symptoms, which allows me to have some more fun and do things that I would not have been able to do as a young child. Like in the photo on the bottom left is one of my best friends and I were playing on a floating obstacle course on a lake. It was one of the most fun times I've ever had. Still one of the rougher experiences, but I planned to carefully, had my treatment schedule set up to where I was on a higher day before participating in an activity like this. But it was a lot of fun, and I am able to kind of do more things than I thought was possible. So still have to be careful, but still can have fun. So yeah, my message today that I really want to show with what I've experienced is take what you have been given, but still keep living. So for the healthcare professionals that may be watching this, please listen to your patients. Keep going with the research. A lot of the research that has come out recently would have been very supportive in my journey growing up and learning how to treat bleeding disorders. So I hope by fostering community and having people share their experiences, we're able to kind of prevent some of the bleeding issues that are not really necessary to have now that there is treatment available. So keep moving forward, keep going with the research, listen to patients who are looking to you to help them find the best treatment options for them. And then for patients and caregivers that are experiencing factor X deficiency and kind of the problems that can come with that, don't let the bleeding disorder define who you are, what you think of life. Just all you are given is your circumstances. So try to do the best that you can with them and keep moving forward, keep finding a treatment plan or an option that works for you, keep living, and just try to stay positive.
That's amazing. Thank you so much, Ariel and Dr. Branchford. I think we've all learned a lot from both of you. Really appreciate you sharing all of your expertise on this. Just before we do dive into our live Q&A, I want to remind our audience to check out the chat. You should find a chat icon at the bottom of your Zoom screen, and you'll see in there that I put a link during our experts' presentations. That link takes you to a whole bunch of resources and information about factor X deficiency. So take a moment to click through to that and maybe save the link or download the PDF so that you can go back to those resources once this webinar ends. We'll also link these resources to the page where the recording will live, so you'll have another chance to look at them there as well. And if you're with us on any of our other platforms, we put it into the comments there as well. So we'll go ahead with our live Q&A now. If you have any questions for our experts, please do pop them into the Q&A at the bottom of your Zoom screen, or you can also put them into the comment section on the other platforms, and we'll try and cover all of your questions. Maybe Dr. Branchford, we can just start with you. Ariel talked about how important research advances have been and how what we know now would have helped her. Can you talk a little bit about what sort of factors have made advances in the treatment for factor X deficiency possible so far, and whether there are any developments that we might hope for in the future?
Yeah, I can think of a few. I think the first one is not necessarily a scientific advancement, but just the ability to participate in webinars like this and reach an audience of interested people and hear from people like Ariel who have lived with this disorder, and just increasing awareness helps make the significance section of grant applications that are being put forth to try to study this a little bit better, lowers the bar there a little bit. If it's a disorder people are a little bit more familiar with, it opens more doors for funding or collaborating or things like this. Number two, I think Ariel did a great job setting up how her brother's experience helped pave the way a little bit for her, in that her parents at least knew what to expect. There was a little bit of a blueprint for the idea of initiating prophylaxis maybe early, given his severe bleed, although the intracranial hemorrhage, even though he had different experience not having menses, but the ability to use a single factor concentrate to replace what's missing and not worry about additional things that come along with it, like with plasma, the potential for viruses or extra volume, or in a prothrombin complex concentrate, the extra factors that may not be necessary, and then you get supratherapeutic levels of those, as Ariel mentioned, and then there's concern about clotting. So being able to focus in on just one factor 10 product. And I think the last thing that comes to mind is this is a different disorder from hemophilia, but I think there are some lessons to be taken from hemophilia in the sense of the options that are out there. Now hemophilia care, we've expanded our approaches, not just extending the half-life of factor 8 or factor 9, but maybe there are ways that we can use a different product, like hemophilia is a bispecific antibody that replaces a mimetic of factor 8, or non-factor therapies, the so-called rebalancing agents that don't necessarily enhance clotting ability, but they reduce clot breakdown ability or clot blocking ability. And so trying to rebalance the clotting system, it's giving us ways of thinking more creatively than just how can we get more factor 10 into this person. And then it's I think a nice side note that a lot of these have improved quality of life too, in addition to being effective and safe. But the fact that they can be subcutaneous injections instead of IV injections, I can imagine that would have made Ariel's life a lot easier earlier on when she was trying to learn how to self-infuse, and that they're long lasting, that sort of thing. So I think we can extrapolate from our experience in other bleeding disorders.
Super, thank you. Ariel, I'd like to ask you, I mean, you touched on what you would like healthcare professionals to know about factor 10 deficiency and people with factor 10 deficiency. So if you'd like to expand on that, I would invite you to, but also I would be really interested to hear from your perspective, are there areas of research you'd really like to see prioritized? You are an expert in living with the disorder, and you are also a researcher. Do you have any thoughts about not necessarily molecular mechanisms, but just things that you think should be a priority for the research?
Yeah. So research-wise, growing up, we were primarily using a complex. So like I mentioned, it has several different factors, and more recently, there's been a straight factor 10 complex that's been available, which has been super, super helpful. But to further that and maybe keep up with a little bit of what the hemophilia products are seeing for factor 8 and factor 9, it would be awesome if one could develop either a subcutaneous injection, because like Dr. Branchford mentioned, yes, that would have been so much easier to learn than venous access for things, or extending the half-life instead of requiring treatments multiple times a week would also be super helpful. Things like that would be really changing quality of life for patients, because although there is a treatment option available, which is awesome, it could still be improved by, reducing the amount of time people are spending just taking care of a bleeding disorder situation. So physical treatments, research furthering, that would be helpful. Also really just extending the amount of research done, like Dr. Branchford's survey, on what patients are experiencing with having a bleeding disorder. Because I was frequently told, well, joint bleeding is not really in the literature for factor 10 deficiency, so you're probably fine. And that was really difficult to just be told growing up that, hey, maybe what I'm feeling isn't real, you know? So having more literature out there that talks about this is what to expect, this is what you can expect, would be super helpful when dealing with a bleeding disorder and talking to your doctor about what to do with certain situations.
Super. Thank you very much for that. And as someone who's also had a doctor say, oh, that you shouldn't be experiencing that. So not helpful. It really doesn't advance anything, does it? We have a nice message from one of our audience members thanking you for the super overview, Brian, and also Ariel for your story, which is very touching and really helps to advance our understanding. So thank you for that. Someone is asking if there is any data on aging with factor 10 and any special considerations for treatment or management as we age.
This came up actually as part of a advisory board I did with Kedrion just last week about hereditary factor 10 deficiency, and none of us on the call were familiar with any relationship with aging. There are certain clotting factors like fibrinogen, von Willebrand factor, factor 8, whose levels slowly climb throughout life. And I think it has to do a little bit with the idea that aging itself is a little bit inflammatory and procoagulant. And as I get older, I'm understanding that more. But factor 10 levels don't seem to change in a meaningful way with age. So the considerations may change though, because older people are more likely to need surgeries, or the clotting balance is a little bit different. By the time you get to be 80 years old, you are at higher risk for clotting for other reasons. So maybe we have to be a little bit more careful replacing factors, or older people are more likely to fall, or that sort of thing, and to have more problems with that, I think is how I would answer that.
Super. Thank you very much. I just wanted to mention to people, I've put another link into the chat, and this is to Community Voices in Research. This is an NBDF initiative, and it's an opportunity for people with bleeding disorders to share their experiences and contribute their data to the understanding of different bleeding disorders. So this is maybe an opportunity that people might be interested in to kind of, whatever your bleeding disorder, to help provide more information on what people really experience with them. So another question here, I think also for you, Dr. Branchford, about any data on inhibitor development when using replacement factor 10?
Yes, not to my knowledge. Flora Pavandis, a researcher who has done a lot of work in this area and kind of led the charge for the reclassification of factor 10 deficiency based on levels that I mentioned in one of the slides. She's published some work on this, and particularly the lack of inhibitor development in response to fresh frozen plasma, which is not exactly the question. There is a study in RPTH, the Research and Practice in Thrombosis and Hemostasis, by Huang et al., a group out of San Francisco, about 15 patients being evaluated for compassionate use of the factor 10 concentrate, and none of those 15 developed inhibitors. I was just looking to see how many that they had a range of levels, but at least 2, 4, 6, I don't know, at least a dozen of them had levels below 1%. So severe, very severe. So despite that, there haven't been reports of it that I know of. And then, do you want me to just jump to the next question?
Yeah, if you want to go ahead and address that, I'll let you go.
So this question is about whether factor 10 deficient patients are more likely to bleed than the general population, or just more likely to have a worse outcome. I would say they are, there's the idea of spontaneous bleeding, but I think they're not truly spontaneous. I don't think hereditary factor 10 deficiency patients are just sitting completely still and all of a sudden a blood vessel pops and starts bleeding somewhere. When we say spontaneous, we really mean like such minor trauma that you would not even notice. The trauma that comes from just swinging your arms as you walk from the couch to the kitchen, for example. So I think we all get those kind of microbleeds all the time, but for people that have normal factor 10 levels or don't have a bleeding disorder, their body's able to quickly patch up that tiny hole. And then the other tiny hole that pops up later that evening when you're brushing your teeth, and the other one that pops up when you do something else. But people with factor 10 deficiency or other bleeding disorders, these little holes in the blood vessel just continue to leak. And they can't stop bleeding as much. So that's where more of the problems come from. So I think that's how I would answer that one.
Great. Thank you very much. Unfortunately, we're out of time. I know we could keep going. We've got lots more questions for you, and I know you've got lots more that you could share with us. So maybe we just need to have you back for another webinar sometime, both of you. But we would really like to thank you both so much, Ariel Lorraine and Dr. Brian Branchford, for sharing your time and your expertise today. We're also super grateful to Kedrion Biopharma for making this webinar possible, and to everybody who's been in attendance. We appreciate you being here. The recording of this webinar will be available shortly on bleeding.org under the events tab. If you select past events, you can find all our archived webinars there, and you can also see what's coming up next. Join us next week when we will discover a treatment option from hemobiologics for the hemophilia community in a sponsored webinar featuring Dr. Guy Young. Thank you so much for joining us today, and have an excellent week.
Thanks, everybody. Have a good day. Happy 10/10 coming up.